Welcome to the module on gynecologic malignancies. My name is Tim Peterson, clinical pharmacy specialist at Sloan Kettering Cancer Center in New York, New York. This presentation is part of the ASHP, ACCP, BCOP Pharmacy Specialty Review course, which is designed for pharmacists seeking to obtain recertification credit or update their knowledge and skills in preparation for board certification. This activity is designed to be interactive with questions posed to you at several points. I will pause to allow you time to consider how you would answer the question. You may wish to write down your answer and the correct response in your handout. The disclosures for this presentation are displayed on this slide. Our learning objectives for this discussion are listed below. The learning objectives below will be discussed entirely in the handout. This will include discussing short and long-term goals for survivorship patients, selecting relevant information and providing guidance to the public relating to gynecologic malignancy-related issues such as prevention and screening, and finally, cervical and endometrial malignancies will be discussed entirely in the handout. Before we get started, we have our first audience response question. Here we have JJ, who is a 57-year-old female who presented to the emergency department with 17 days of abdominal distension and 3 days of abdominal pain. Physical exam revealed a mass in her right lower abdomen. Her laboratory results were notable for a hemoglobin of 7.1 and a CA-125 of 212. An ultrasound confirmed presence of a mass and imaging ruled out distant metastases. The patient is clinically staged with 1B high-grade serous ovarian cancer and underwent adequate surgical cytoreduction. Which of the following is the most appropriate management for JJ at this time? The correct answer here is C, carboplatin and paclitaxel for 6 cycles. This is because 6 cycles of platinum-based combination chemotherapy is recommended as adjuvant therapy for patients with early-stage, high-grade serous ovarian cancer. This is based on the subgroup analysis of GOG 157, which showed favorable recurrence-free survival with 6 cycles over 3 cycles for high-grade serous histology. This makes A and B incorrect. Option D is incorrect because Bevacizumab-based combination therapies are not recommended for stage 1 disease. These may be utilized for stage 2 through 4 disease. Delving into the treatment paradigm itself, so the very first thing is obviously going to be surgical management. So we need comprehensive surgical staging for basically everyone. Here we're looking at total abdominal hysterectomy or TAH, bilateral salpingo-oophorectomy or BSO, some of the pelvic and para-aortic lymph node dissections, omentectomy, radical pelvic dissection. Other resections will occur as necessary once the procedure is actually underway. But comprehensive surgical staging is very important. This is important even for early stage women because women with early stage disease on about up to 30% of cases will actually be upstaged, and this can have drastic implications with regard to adjuvant therapy, observation versus intensive chemotherapy, number of cycles. Those sorts of treatment decisions are very much so based on the surgical staging itself. When we look at definitions of cytoreduction, optimal cytoreduction is technically defined as less than 1 centimeter of residual disease after the debulking surgery. Suboptimal clearly then is greater than 1 centimeter residual disease, but ultimately the obvious goal is going to be microscopic. So we have no visual residual disease, but that's not always attainable. So when we look at some of the clinical practice guidelines, some of the historical studies that will help us to guide management decisions, optimal cytoreduction is generally going to be the goal of your cytoreductive therapy. During surgical cytoreduction and surgical staging, it's recommended by the clinical practice guidelines to undergo tumor molecular testing as well. This may help to guide not just primary therapies, but maintenance therapies. So we should be looking at germline and or somatic BRCA 1 and 2 evaluation, homologous recombination deficiency. This is going to be looking specifically at moderate penetrance genes, which may increase susceptibility of the tumor subtype to PARP inhibition. So we know that PARP inhibitors can be used in the setting of primary maintenance therapy. They can be used in recurrent maintenance therapy, and they can also be used in recurrent treatment. So whether or not we have homologous recombination deficiency can help to guide the potential benefit of PARP inhibition. Looking into surgical techniques for early stage, specifically ovarian cancer, for the most part, you should be trying your best to avoid a fine needle aspirate. The idea for this is that patients who are presumed to have early stage disease based on imaging, there's a theoretical risk that you could rupture the ovarian cyst, causing spilling of the malignant cells into the peritoneum. And you can imagine that you have spilling of these malignant cells in the peritoneum, then we're already looking at local regional spread of the disease, and that's already affecting the management strategies. For the surgical techniques themselves, stage 1, you can, under certain circumstances, allow for fertility preservation. Specifically, stage 1A disease, you can do a USO, which is a unilateral salpingo-oophorectomy, and comprehensive surgical staging. This allows us to preserve the contralateral, unaffected ovary, as well as the uterus. Stage 1B, you need to perform a bilateral salpingo-oophorectomy, BSO. So obviously here, we're not preserving the contralateral nor the ipsilateral ovary. We are just preserving the uterus, and then still undergoing comprehensive surgical staging. So these women, yes, there is fertility preservation, but they are obviously going to require assistive reproductive techniques. Now, anyone with stage 1 disease who does not desire fertility preservation, or anyone with stage 2, regardless, unfortunately, of their fertility desire, should undergo comprehensive surgical staging, as was prior discussed. So that includes the total abdominal hysterectomy, the bilateral salpingo-oophorectomy, omentectomy, any lymph node dissections, and additional resection and biopsies that are necessary during the procedure. Following initial surgical cytoreduction and comprehensive surgical staging, patients in the early stage setting, stage 1, should be considered for observation or chemotherapy in the adjuvant setting. Now, this is based not just on staging, but it's also based on the histologic subtype of ovarian cancer. So to touch briefly on the histologies, our most common histology is going to be serous. Serous histology makes up 75 to 80% of ovarian cancer diagnoses. Now, this is divided into low-grade serous, which is actually just grade 1, or high-grade serous, which is either grade 2 or grade 3. The other subtypes, histologies, are either grade 1, 2, or 3, and are not delineated as low-grade versus high-grade like serous is. The next most common is endometrioid. Endometrioid makes up about 10% of cases. And then we have clear cell, which brings with it an adverse prognosis with it. Lastly is mucinous. It's 5% or maybe less than 5% of occurrences, and this is oftentimes metastases from a gastrointestinal primary malignancy. So you'll see patients being worked up to rule out a primary gastrointestinal malignancy as opposed to a primary ovarian cancer, and throwing in associated testing such as HER2 and things of that sort that may be associated with the gastrointestinal primary. When we look at management of stage 1A and 1B disease, if a patient has low-grade serous, meaning just grade 1 serous, or grade 1 endometrioid, then you can do surgical staging followed by observation. This obviously makes up a very small set of patients because most patients do need to proceed on to adjuvant therapy. For grade 2, and again, this is going to be grade 2 endometrioid as per this slide, right? Because grade 2 serous would inherently be high-grade serous. So these patients with grade 2 non-serous subtype can get surgical staging followed by observation or platinum-based chemotherapy for 3 to 6 cycles, depending on other clinical situation. For patients that have stage 1A and 1B high-grade serous, again, so grade 2 or grade 3, or they have grade 3 of another histology, or if they're stage 1C completely independent of the histology that they have, surgical staging followed by platinum-based chemotherapy for 3 to 6 cycles is recommended. And now where we get into our audience response question is that 6 cycles are actually recommended for high-grade serous, which is what our patient had in our audience response question. Now that we've decided whether or not to provide adjuvant chemotherapy in the early stage setting, how do we decide what regimen to provide? So the way the clinical practice guidelines are set up these days is they have a delineation based on age. So less than the age of 70, in the absence of significant comorbidities that may affect their ability to tolerate therapy, these are the recommended regimens for early stage disease. We have our preferred regimen, which is going to be far and away the most common, which is carboplatin in combination with paclitaxel on the top. We also have carboplatin in combination with liposomal doxorubicin and carboplatin in combination with docetaxel. For patients in the early stage setting, having undergone their surgical staging, if they're above the age of 70 years or they have medical comorbidities that may affect their ability to tolerate therapy, we have these additional options. So the first one is carboplatin in combination with paclitaxel. The difference here, the only difference compared to the last slide, is the paclitaxel dose is reduced to 135 milligram per meter squared. The second option, clearly monotherapy carboplatin, much more mild compared to doublet therapy with carboplatin and paclitaxel. And then finally, we have dose-reduced carboplatin and paclitaxel on a weekly basis. So this is carboplatin at an AUC of 2 in combination with paclitaxel 60 milligram per meter squared on a weekly basis. The first landmark trial we'll look at is that of chemotherapy in early-stage ovarian cancer in the GOG 157 study. In this study, we had patients with high-risk features, stage 1A, 1B disease with grade 3, or stage 1C, stage 2, or clear cell. Recall, we know clear cell has a poor prognosis at baseline. These patients were randomized to receive either 3 or 6 cycles of standard carboplatin in combination with paclitaxel. Recurrence rate was about 24% lower in patients that received 6 cycles, but this didn't meet statistical significance, nor did it correlate with a difference in overall survival. Toxicity, as you would expect, giving patients more, twice as much conventional chemotherapy, toxicity was higher in patients that received 6 cycles. So this, in and of itself, didn't tell us that patients really needed 6 over 3 cycles. It was more toxic and it didn't provide any benefit. Fast forward to a subgroup analysis for this same study. This looked at patients with serous tumors, specifically comparing 6 cycles versus 3 cycles. You can see that they actually had a lower risk of recurrence that was statistically significant with 6 cycles of chemotherapy in serous subtype compared to 3 cycles. The 5-year recurrence-free survival was 83% with 6 cycles compared to 60% with 3 cycles. This led to the clinical practice guideline recommendation that patients with early stage disease and serous histology should receive 6 cycles in lieu of 3 cycles compared to the other histologies. To summarize the primary treatment of early stage 1 disease, comprehensive surgical staging is important for everyone. You may consider fertility-sparing procedures for stage 1A and 1B depending on the clinical situation. Acceptable chemotherapy would include platinum-based therapies, carboplatin with paclitaxel, liposomal doxorubicin, or docetaxel, and these can be dose attenuated for patients who are elderly or with significant comorbidities, including doing monotherapy with carboplatin or dose attenuating paclitaxel and or carboplatin. Here we have adjuvant chemotherapy options for patients with stage 2 to 4 disease. You'll note that many of these are similar to the slide we looked at for stage 1 disease. However, these are going to be 6 cycles, and there's no consideration for 3 to 6 cycles based on histology, as there would be for early stage. In addition to our standard options, we now have incorporation of bevacizumab. Bevacizumab may be given as 15 milligram per kilogram, as per GOG 218, or 7.5 milligrams per kilogram as per ICON 7. It should be noted that both of these regimens should then continue on to the maintenance setting because there's no significant benefit in progression-free survival without that maintenance therapy. We also have the introduction of dose-dense paclitaxel. This gets into a little bit of controversy, which we'll talk about, with regard to potential progression-free and overall survival benefit that may or may not be contingent upon patient's ethnicity itself. Finally, on the bottom right, we have intraperitoneal therapy with cisplatin and paclitaxel. This can significantly improve the progression-free and overall survival, but it comes with it significant toxicities. These toxicities are very profound, and they need to be taken into consideration when you're screening patients for potential intraperitoneal therapy. We'll talk a little bit more in depth about that momentarily. Here again, we have the recommendations for adjuvant chemotherapy for patients above 70 years old with or without medical comorbidities. You'll notice this slide is basically the same. It's the same recommendations for these patients who are elderly with or without comorbidities as it was for stage 1. So again, we have dose attenuation of paclitaxel in combination with carboplatin monotherapy, dose attenuated paclitaxel and carboplatin on a weekly basis as per the MITO 7 study. All of these are looking at improving tolerance for a little bit more mild therapy for patients that need that help in tolerating therapy. Looking a little bit more closely at dose-dense paclitaxel, the original study that showed the potential benefit of dose-dense paclitaxel being that 80 milligram per meter squared on a weekly basis instead of the 180 milligram per meter squared every 3 weeks. This is the Japanese GOG group. They looked at a large amount of patients with newly diagnosed disease, stage 2 to 4, and they actually found a statistically significant improvement in not just progression-free survival, but overall survival Overall survival, as you can see, was increased from 62 months to 100 months. They obviously saw increases in myelosuppression, particularly grade 3 to 4 anemia with the weekly dosing, and they did see reduction in quality of life overall. So the toxicity profile was significant, but there was also a very large benefit in increases in progression-free and overall survival. The concern with regard to the JGOG dose-dense paclitaxel study is whether or not we can actually extrapolate these responses in progression-free survival and overall survival to non-Asian ethnicity patient populations. So the ICON-8 study actually looked at a primarily European patient population with newly diagnosed disease. It was 3-arm, but we're looking primarily at the dose-dense group, which was in the middle here with paclitaxel 80 milligram per meter squared. And what they found was that there was no significant improvement whatsoever in progression-free survival with the addition of dose-dense paclitaxel, nor was there any difference in overall survival, albeit this was preliminary overall survival as the data is not mature. As you would expect, the toxicities were increased with dose-dense paclitaxel, with grade 3-4 toxicities being higher with the weekly dosing. So this brings to question that, yes, this is actually proof of concept and confirmation that dose-dense paclitaxel can be safely given, but we don't necessarily know the potential benefit in progression-free and overall survival. So this is something you may still see in clinical practice with relative regularity for young, relatively fit women who are able to tolerate this therapy that we know may cause more toxicities. As was mentioned, intraperitoneal therapy with cisplatin and paclitaxel is recommended by the clinical practice guidelines for patients with stage 2 or stage 3 disease. This is based primarily on data from Armstrong et al. In the GOG 172 study. This looked at patients having attained an optimal cytoreduction, less than 1 centimeter of residual disease, specifically with stage 3 disease. So the NCCN recommendations for stage 2 are primarily an extrapolation of this data. They were randomized to either standard intravenous cisplatin in combination with paclitaxel or intraperitoneal cisplatin and paclitaxel with also IV paclitaxel listed on the bottom left there. You can see there were significant improvements in progression-free survival from 24 months compared to 18 months with the intravenous treatment. Also, overall survival was improved from 50 months up to 66 months, and this was statistically significant. Of note, though, and as you may expect, as we talk about in the next couple of slides, patients who actually completed the planned 6 cycles of therapy significantly less in the intraperitoneal group compared to intravenous, with only 42% of patients completing the planned 6 cycles with intraperitoneal therapy compared to 83% of patients with intravenous therapy. This slide outlines the reason for why so many patients in the intraperitoneal arm struggled to complete the 6 planned cycles when compared to intravenous therapy. The table is grade 3 and 4 adverse events, and all of these are significantly higher in the intraperitoneal group. So myelosuppression, GI events, nausea, we know that cisplatin is already highly emetogenic when given intravenously, but it's even more emetogenic when it's given intraperitoneally. Metabolic derangements, abdominal pain, infections, and actually nephrotoxicity. Again, another thing that we think about with cisplatin is nephrotoxicity, but when given intraperitoneally, there were even more nephrotoxicity events compared to intravenous administration. So this is something that attunes to the fact that we need to be very cautious in patient selection for intraperitoneal therapy. Yes, there is significant benefit to be derived, but you need to be very careful in patient selection. The clinical practice guidelines recommend that anyone undergoing surgery for stage 2 and 3, and again, stage 2 is an extrapolation from this prior data, should be counseled regarding the potential risks and benefits. The risks clearly are definitely there, but also the benefits are definitely there for the correctly selected patient. So these patients would include patients primarily with stage 3C would be preferred with optimally debulked tumor less than 1 centimeter in the adjuvant setting, no history of rectosigmoid bowel resection at the time of primary surgery, of good performance status because of this difficulty to tolerate therapy, normal renal function because of the cisplatin, again, the increase in nephrotoxicity with intraperitoneal compared to intravenous therapy, and no pre-existing neuropathy with the cisplatin and paclitaxel. Numerous retrospective experiences and review articles have also been published on ways to mitigate some of the toxicities that can be associated with intraperitoneal chemotherapy. Most of these have been widely adopted, but the first thing is to warm the intraperitoneal fluid to reduce some of the shock that can cause the pain and discomfort associated with administration. We obviously need very aggressive oral and IV hydration pre and post therapy, owing in part to the nephrotoxicity of cisplatin. We know that it's even greater with intraperitoneal therapy. Similarly, the emetogenicity of cisplatin, we know it's very high. We need to anticipate that acute and delayed emetogenicity associated with cisplatin. Schedule modifications, the way that this was originally administered with the Armstrong study, they modified this to make this better improved and better tolerated. So Paclitaxel is given over 3 hours instead of 24 hours, which is how it was originally studied. Cisplatin is given at 75 milligram per meter squared, originally studied at 100 milligram per meter squared. So some of these modifications to the schedule, dosing, and administration have helped to significantly improve the tolerability of this regimen. For our next audience response question, we have SM, who presents for a pelvic ultrasound that confirms a left adnexal mass. She has a subsequent biopsy which reveals high-grade serous carcinoma. Additional staging confirms that SM has clinical stage 4B based on pleural effusions and liver lesions, ovarian cancer. She's also deemed upon imaging and in consultation with surgery to be unlikely to be optimally cytoreduced. Which of the following is the most appropriate initial therapy for SM? The correct answer here is C, dose-dense paclitaxel in combination with carboplatin, followed by an interval debulking surgery. This is because patients who are deemed to be unfit for surgery or unlikely to be optimally debulked should be considered for neoadjuvant chemotherapy prior to their surgical cytoreduction. This also makes A incorrect. B is incorrect because intraperitoneal therapy should not be used as neoadjuvant treatment prior to a debulking surgery. Rather, these may be used after an interval debulking surgery as adjuvant therapy. D is incorrect because although carboplatin, gemcitabine, and bevacizumab is a reasonable combination therapy, this is a combination that should be used in the setting of platinum-sensitive recurrence, but not in the frontline setting. As was discussed with our audience response question, neoadjuvant chemotherapy should be considered for bulky stage 3 and 4 disease if a patient is deemed to be unlikely to be optimally cytoreduced to less than 1 centimeter of residual disease, or if they're a poor surgical candidate. This clearly requires histologic confirmation of the diagnosis through biopsy and/or paracentesis. Patients should be assessed for potential cytoreduction following 3 cycles of neoadjuvant chemotherapy, and surgery is generally preferred to occur after 3 to 4 cycles. A minimum of 6 total cycles should occur, with at least 3 of those being adjuvant after the interval debulking surgery. You may consider more than 6 cycles in patients who have stable disease. As per the clinical practice guidelines, the recommended regimens for neoadjuvant chemotherapy prior to an interval debulking surgery are any intravenous regimen that are recommended for stage 2 through 4 disease. And please note that this does not include our intraperitoneal therapies. Bevacizumab-based intravenous therapies may be used, but should be used with caution. This is because of the wound healing complications that we know can be associated with VEGF inhibition. So if bevacizumab-based therapy is used for primary neoadjuvant therapy, you must hold bevacizumab for at least 6 weeks prior to the interval debulking surgery to reduce postoperative healing complications. Following the interval debulking surgery as adjuvant chemotherapy, you may use, again, any recommended intravenous therapy for stage 2 through 4 disease. However, now you may also use intraperitoneal therapy with cisplatin and Paclitaxel, or our first introduction of intraperitoneal therapy with carboplatin and Paclitaxel. And this is based on a study that's down in the references below per Proventure. You may also consider for stage 3 disease at the time of interval debulking surgery, HIPEC, which is hyperthermic intraperitoneal chemotherapy. In our next audience response question, we have SM, who's completed 3 cycles of neoadjuvant chemotherapy. She underwent interval debulking surgery, attaining an optimal cytoreduction, and she subsequently completed 3 more cycles of adjuvant chemotherapy with Paclitaxel and carboplatin. Her response to therapy was a CR, and following genetic testing, her tumor was found to be BRCA1 and 2 wild type. SM would like to pursue maintenance therapy. Which of the following would you recommend? The correct answer is B, Niraparib, 300 milligrams once daily. Niraparib is currently the only PARP inhibitor that's approved for primary maintenance therapy following a CR or a PR to platinum-based chemotherapy, independent of BRCA status. A is incorrect because bevacizumab-based maintenance therapy should be reserved for patients who receive bevacizumab-containing primary therapy as per either GOG-218 or the ICON-7 studies. Olaparib is incorrect because the use of Olaparib is actually restricted in the primary maintenance setting to patients with either a somatic or germline deleterious BRCA 1 or 2 alteration who are in a CR or PR to primary platinum-based chemotherapy. Now we'll discuss the primary maintenance therapy options in patients following their initial adjuvant therapy. This includes bevacizumab, as per the GOG-218 or ICON-7 studies, bevacizumab in combination with Olaparib, Olaparib monotherapy, and Niraparib monotherapy. So the first maintenance therapies that we'll talk about in the primary setting are those incorporating bevacizumab. So for these studies, we have GOG-218 and ICON-7. And I do want to point out that bevacizumab is actually FDA approved in the front line for stage 3 and 4 disease. However, the NCCN clinical practice guidelines extrapolate that to allow for its incorporation into stage 2 on top of stage 3 and 4 disease. So these bevacizumab-based primary induction therapies proceeding on to maintenance therapy are actually reasonable in the context of stage 2 through 4 disease. So the first study that we have is the GOG-218 study. This is looking at carboplatin in combination with Paclitaxel plus or minus bevacizumab. So bevacizumab was given as 15 milligram per kilogram every 21 days, beginning with the first day of the second cycle. They then continued on to a maintenance schedule up to 22 total cycles. You can see that the progression-free survival was significantly improved, albeit by only 4 months with the addition of bevacizumab, and overall survival, specifically looking at the subgroup of patients who had stage 4 disease at diagnosis, was significantly improved from 32.6 to 42.8 months. So the indication, again, like I mentioned, is going to be for first-line stage 2 to 4 in combination with carboplatin and Paclitaxel, but then it is definitely recommended that you continue, as per the study, onto maintenance therapy with bevacizumab. The second bevacizumab-based trial we'll look at in the front line, moving on to maintenance therapy, is the ICON-7 study. Again, we're looking at standard carboplatin in combination with Paclitaxel, now incorporating bevacizumab at a dose of 7.5 milligram per kilogram every 21 days for 5 to 6 cycles with that platinum doublet, and then continuing up to 12 additional cycles of maintenance therapy. Progression-free survival, although it was statistically significantly prolonged, was only about 2 months of prolongation from 22 to 24 months. And then overall survival, though, was significantly higher in patients who were high risk when they added bevacizumab. So high risk in this study was deemed by patients that had stage 3 disease with greater than 1 centimeter of residual disease, so not optimally cytoreduced, patients that were deemed to be inoperable of stage 3, or stage 4 patients. So potentially an additional niche when we're looking at stage 4 patients really benefited in the GOG-218. We also have these high-risk patients that may benefit based on the ICON-7 study too. Similar indication as per the clinical practice guidelines, we're looking at stage 2 through 4 in this standard combination with carboplatin and Paclitaxel. As with 218, we do suggest that you continue on to bevacizumab maintenance because that is truly where the benefit is derived. One of the newcomers to the primary maintenance therapy setting in ovarian cancer is the combination of Olaparib with bevacizumab. This is based on the PAWLA-1 study, which looked at bevacizumab plus or minus Olaparib. For patients who received Olaparib, it was 300 milligrams twice daily for up to 2 years, standard dosing. All patients received bevacizumab at 15 milligram per kilogram every 3 weeks for a total of 15 months. The efficacy, when we look at the intention to treat all-comer patient population, progression-free survival was prolonged from 16.6 to 22.1 months. But when we look more specifically at different subgroups, including those that had a BRCA wild type with homologous recombination deficiency, making them potentially more apt to respond to PARP inhibition, PFS was prolonged from 16.6 to 28.1 months. Looking even further, those that have an actual BRCA mutation, they had a prolongation of progression-free survival from 17.7 to 37.2 months. These results listed on this section of the table kind of owe into where the clinical practice guidelines went with their indications. So broadly speaking, the indication for this combination is patients in a PR or CR to first-line platinum-based chemotherapy, assuming that original platinum-based chemotherapy included bevacizumab. And then if they had a germline or somatic BRCA mutation, it's a category 1 recommendation. This strong recommendation comes from that bottom part of the middle table here. Patients had significant improvement in PFS. Patients, independent of their BRCA status, though, can still benefit from this therapy. That's shown from the intention to treat at the top of the table. Patients who were BRCA wild type without homologous recombination deficiency still had prolongation of about 5.5 months of progression-free survival. Those with BRCA wild type and homologous recombination deficiency were somewhat in the middle, as you might expect. So these are where the indications for this combination therapy in the primary maintenance setting come from. Our first PARP inhibitor monotherapy in the setting of primary maintenance is Olaparib, and this is based on the SOLO-1 study, in which Olaparib at standard dosing again was compared to placebo. Based on recent 5-year updates that were presented at ESMO last year, you can see that the progression-free survival was significantly improved, with a hazard ratio of 0.33 and progression-free survival of 56 compared to 13.8 months. Now, this patient population was those that had somatic or germline BRCA mutations, which is why the indication in this context is restricted to patients with a somatic or germline BRCA mutation. It's also why that significant PFS benefit is so broad compared to some of the intention to treat analysis for some of the other studies of PARP inhibition. So the indication for Olaparib in the primary maintenance setting would be patients in a PR or CR to first-line platinum-based chemotherapy with a somatic or germline BRCA mutation. Niraparib makes up our last primary maintenance therapy that we have available. This is based on the PRIMA study, which looked at Niraparib maintenance versus placebo. Standard Niraparib dosing of 300 milligrams once daily was utilized, and you can see this annotation we'll talk about on the next slide with regard to potential dose reductions. In the intention to treat all-comer patient population, the progression-free survival was significantly improved from 8.2 to 13.8 months. Importantly also was progression-free survival in patients that were HRD or homologous recombination deficient was significantly improved as well, even more, as you might expect, because these patients are, again, more apt to respond to PARP inhibition. So ultimately, the indication for Niraparib was then derived to be patients in a PR or CR to first-line platinum-based chemotherapy, again, who are BRCA wild type owing to that all-comer PFS benefit, or with a somatic germline BRCA mutation. We see more benefit in patients that are BRCA mutated or those that have homologous recombination deficiency, independent of BRCA mutation status. But importantly for Niraparib in the primary maintenance setting is that this is indicated for people who are BRCA wild type, as opposed to Olaparib, which is specific to somatic and germline BRCA mutations. For Niraparib dosing, we know that 300 milligrams once daily is standard, regardless of the study that's being utilized. However, there was a retrospective analysis of a NOVA trial, which is looking at the relapse refractory setting. They found that nearly 70% of patients experienced dose reductions, nearly 15% had discontinued therapy, and 3.3% of these patients, it was due to thrombocytopenia. So they looked at different risk factors to account for what could actually be driving these dose reductions that are needed. They found that baseline body weight and platelet count were identified as risk factors for thrombocytopenia and dose reduction. As such, it's recommended to consider a reduction to 200 milligrams instead of 300 milligrams daily in patients that have a baseline weight less than 77 kilograms or a baseline platelet count less than 150,000. This is something that they're still kind of incorporating in some of the ongoing clinical trials, but it's dosing that you'll definitely see in clinical practice. We'll now transition to the management of recurrent ovarian cancer. We now have SM who presents to the clinic 2 years after completing adjuvant chemotherapy, which was complicated by grade 2 peripheral neuropathy. She's remained on Niraparib maintenance, but due to recent abdominal distension, a CT scan was completed revealing new lymphadenopathy and confirmed disease recurrence. SM is concerned about worsening peripheral neuropathy with receiving treatment again. Which of the following regimens is most appropriate for SM at this time? The correct answer is A, carboplatin in combination with gemcitabine. This patient has a platinum-sensitive relapse, having relapsed after at least 6 months of initial induction therapy. We know that cisplatin may contribute more to peripheral neuropathy than carboplatin, making D incorrect. A would be preferred because carboplatin has a lower propensity to cause neuropathy compared to cisplatin. Carboplatin may be given in the relapse setting with either gemcitabine or liposomal doxorubicin in lieu of Paclitaxel to prevent further exacerbation of peripheral neuropathy. B would not be preferred because the patient already had grade 2 neuropathy to her prior experience with Paclitaxel. She also expressed explicit concern regarding this potential adverse effect, so we would not want to re-challenge her with Paclitaxel. C is inappropriate because although this is a reasonable option in the setting of platinum-resistant relapse, we know that this patient has a platinum-sensitive relapse and we should be re-challenging her with platinum-based therapy. In the setting of recurrent ovarian cancer, we know that the goal of treatment is no longer cure. Now we're looking to improve the patient's symptoms, improve their quality of life. We're looking to achieve an objective response and prolong survival as long as possible. There's really no standard therapy other than platinum-sensitive versus platinum resistance. Treatment is then dictated by duration of their first remission, prior toxicities, patient convenience, quality of life, and unfortunately, third-party payer authorization. You may consider, under certain circumstances, a secondary cytoreduction for platinum-sensitive relapses, and there are multiple maintenance therapy strategies, particularly PARP inhibitors, which we'll discuss, for the management and maintenance of platinum-sensitive relapse. The duration of response to prior therapies is the biggest driver of decision-making in recurrent ovarian cancer. We know that the prognosis and treatment is defined by their initial response to therapy. Primarily speaking to platinum sensitivity, platinum-sensitive disease is defined as a platinum-free interval greater than 6 months. Platinum resistance is defined as platinum-free interval less than 6 months, and platinum refractory is when no response to or progression on platinum-based therapy occurs. These are important definitions to think about when we're looking at treatment decisions in the relapsed and refractory setting of ovarian cancer. Prior to initiating therapy for recurrent ovarian cancer, the clinical practice guidelines recommend that tumor molecular testing be performed if it has not been performed before. Specifically, it's recommended to include at least BRCA 1 and 2 and microsatellite instability testing, or DNA mismatch repair. It may also include homologous recombination deficiency testing, and this may help to guide therapy with PARP inhibitors and maintenance PARP inhibitor therapy considerations. Looking first at platinum-sensitive recurrent disease, clearly we know that response to prior therapy is going to play a huge role in our therapeutic decision-making in recurrent settings. So patients that have platinum-sensitive disease, we still want to maintain that platinum backbone. So we look at carboplatin in combination with gemcitabine or paclitaxel or liposomal doxorubicin. Any of those can be with or without bevacizumab. We have cisplatin in combination with gemcitabine as an option. Looking at targeted therapies, any of our 3 PARP inhibitors can be used in the treatment of recurrent disease. These are going to vary based on the number of lines of therapy and on mutational status. So if you think about it, Olaparib came around first. It was initially approved after 3 lines, but it was updated by the guidelines to be after 2 lines. And it looked specifically at germline mutated. Rucaparib, after 2 lines, looked at germline and then added on somatic mutations because they know that patients can also benefit with somatic mutations to PARP inhibition. Niraparib, after 3 lines of therapy, looked at patients with BRCA mutation, but also genomic instability, including those with homologous recombination deficiency. Again, just looking at another small subset of patients that can benefit from PARP inhibition. Lastly, we have Niraparib in combination with Bevacizumab, and this is actually a chemotherapy-sparing option in the platinum-sensitive recurrent setting, which is a new option based on the AVA Nova study we'll talk about momentarily. The first study we'll talk about in the relapse setting, platinum-sensitive recurrence, is the ICON-4 trial. Basically, this is our historical context and proof of concept that you can re-challenge with a platinum-based regimen. So this study importantly showed that there was a survival benefit with re-challenging patients to platinum and taxane when they had received prior platinum-based therapy. So it was a statistically significant improvement in survival. However, there are a couple of things to keep in mind with this study. One is that 60% of patients had not received prior Paclitaxel. So we're exposing them to a novel conventional chemotherapeutic agent that their malignancy had not seen before. They're apt to respond to this. Additionally, 75% of patients had a platinum-free interval that was actually greater than 12 months. Recall that greater than 6 months is all we need to satisfy the requirement for definition of platinum-sensitive recurrence. So the longer the platinum-free interval is, the better the prognosis in general, the more likely they are to respond to therapy. Clearly, they responded quite well to platinum-based therapy in the first place. So things to keep in mind when we're thinking about this study. But again, this is more of a proof of concept that we can re-challenge with platinum-based therapies. 2 additional specific options that we have for platinum-sensitive recurrence would be carboplatin in combination with liposomal doxorubicin, or in combination with gemcitabine. So if you look at Calypso here, It's carboplatin with liposomal doxorubicin, standard dosing of 30 milligram per meter squared of liposomal doxorubicin given every 28 days, and this was being compared to carboplatin paclitaxel standard platinum doublet. Median progression-free survival was actually prolonged with the combination of carboplatin and liposomal doxorubicin compared to carbotaxol, but there was no significant difference in overall survival. Toxicity profile, there was more toxicity in general when you look at carboplatin and paclitaxel, being hypersensitivity, neutropenia, alopecia, and peripheral neuropathy. So this is more so showing that this is non-inferior. It may have progression-free survival benefit compared to carboplatin paclitaxel, but it's certainly an alternative when you're looking at toxicity profiles to try to omit the paclitaxel. Similarly, looking at carboplatin with gemcitabine in this intergroup study, so we have gemcitabine given as 1,000 milligram per meter squared on days 1 and 8 of a 21-day cycle, and this was just looked at compared to carboplatin monotherapy. Median progression-free survival, as you would expect, was prolonged with the addition of gemcitabine to carboplatin. Again, there was no difference in overall survival. More myelosuppression, as you would expect, adding conventional chemotherapeutic agent to carboplatin monotherapy, and no difference in quality of life. So again, both of these are reasonable options to be incorporated for platinum-sensitive recurrence when you're wanting to omit paclitaxel, potentially for toxicity profile reasons, history of peripheral neuropathy, history of hypersensitivity reactions to taxanes in the past. These are reasonable options as alternatives. Now we'll look closer at bevacizumab in the context of platinum-sensitive recurrence. The first study is the OCEANS trial, which looked at carboplatin and gemcitabine with or without bevacizumab. You can see that incorporation of bevacizumab prolonged progression-free survival by about 4 months, and it was statistically significantly so. Overall survival was no different, and the adverse effect profile is what you may expect from a VEGF inhibitor, including hypertension and proteinuria. Looking next at the OVAR study, carboplatin and liposomal doxorubicin with bevacizumab was compared to carboplatin, gemcitabine, and bevacizumab. Progression-free survival with liposomal doxorubicin was prolonged, as well as overall survival. The toxicity profile was greater with gemcitabine, specifically for grade 3 to 4 toxicities, and the mean dose intensity was higher with liposomal doxorubicin compared to gemcitabine. Lastly is our chemotherapy-sparing option, which is looking at Niraparib with bevacizumab compared to Niraparib. Progression-free survival was significantly prolonged from 5.5 to 12.5 months with the addition of bevacizumab to Niraparib. However, the overall survival data was not mature. It should be noted that this study did not look at a standard platinum-based comparator arm in the setting of platinum-sensitive recurrence, and although this is chemotherapy-sparing, we know that in the setting of platinum-sensitive recurrence, platinum backbones are generally preferred. Certainly, there are a subset of patients who could benefit from chemotherapy-sparing options in this context, but this comparator arm is not standard, and it's difficult to take too much away from this study. With further incorporation of bevacizumab in the front line, owing to GOG218 and ICON-7, and now with our initiation potentially of Olaparib in combination with bevacizumab maintenance therapy in the front line, the question has come up with regard to whether we can re-challenge patients who've been exposed to bevacizumab with more bevacizumab in the relapse setting. So the MITO16B MANGO study looked at patients in platinum-sensitive recurrence who had received a bevacizumab-based primary therapy and randomize them to platinum-based doublet therapy in the relapse setting with or without bevacizumab. Progression-free survival with the addition of bevacizumab was prolonged by 3 months, significantly so, but there was no difference in overall survival. This study basically tells us that although we're now incorporating more and more bevacizumab in the front line, the sequencing is such that we may be able to re-challenge patients with additional bevacizumab-based therapies in the platinum-sensitive recurrent setting and derive benefit from that. Patients who have responded to a platinum-sensitive recurrent therapy may continue on to maintenance therapy in the recurrent setting. Patients who have received a bevacizumab-based salvage therapy, if they continue to respond to therapy, may continue bevacizumab as monotherapy maintenance, or you can consider any of the 3 PARP inhibitors. PARP inhibitor maintenance may be considered for patients who attain a PR or CR to recurrent therapy in the platinum-sensitive setting. This is actually independent of BRCA status, although it is preferred for BRCA mutated because we know that BRCA mutated is more likely to respond to PARP inhibition. So any of the 3 PARP inhibitors may be used for recurrent maintenance therapy following a response to platinum-sensitive recurrent therapy. This includes Olaparib, Rucaparib, and Niraparib. The first maintenance study of PARP inhibition in recurrent platinum-sensitive disease is Niraparib in the NOVA trial. Patients with platinum-sensitive recurrent disease were randomized to receive maintenance Niraparib at a standard dose of 300 milligrams or placebo orally daily. They found that patients had prolonged progression-free survival regardless of if they attained a PR or a CR, and regardless of if they were germline BRCA mutated or non-germline BRCA mutated. This is owing to the fact that this indication for Niraparib in platinum-sensitive recurrent maintenance therapy is actually irrespective of BRCA mutational status. Important also for maintenance-type studies is if we're looking at placebo or no therapy versus an active drug therapy for maintenance, quality of life was actually similar between groups between Niraparib and placebo. Two studies looking at Olaparib in the recurrent platinum-sensitive maintenance setting are Study 19, which looked at the old formulation of capsules, which now do not exist, and Solo 2, which looked at the tablet formulation. In Study 19, originally, they looked at maintenance Olaparib at a different dose from what's utilized now compared to placebo, and this was independent of BRCA status. They found prolonged progression-free survival from 4.8 to 8.4 months. And in the long-term analysis, they actually had 32 patients who received Olaparib for over 2 years. And the median overall survival was significantly improved with Olaparib maintenance, independent of BRCA status. Now, with the Solo 2 study, they looked specifically at platinum-sensitive recurrent disease that was germline BRCA mutated. So because of this, you would expect even more significant median progression-free survival benefit, and that's exactly what they showed. The median progression-free survival was 19.1 months with Olaparib compared to 5.5 months with placebo. Long-term analysis showed significant improvement again in overall survival. And similar to Niraparib, the quality of life outcomes were similar between placebo and maintenance Olaparib therapy. Lastly, for maintenance therapy in platinum-sensitive relapse, we have Rucaparib. Rucaparib, they again randomized patients 2-to-1 to maintenance Rucaparib versus placebo. You can see initially looking at the intention to treat population, there was already progression-free survival benefit, noted from 5.4 to 10.8 months. When you add in homologous recombination deficiency, patients responded even better. Progression-free survival then increased to 13.6 months. And lastly, BRCA mutation. When you added that into the mix, the median progression-free survival improved even further to 16.6 months. So again, we already have benefit in the intention to treat population independent of homologous recombination deficiency or BRCA mutational status with the addition of Rucaparib PARP inhibition maintenance therapy. For our next audience response question, we again have SM, who has now received 5 lines of chemotherapy, most recently topotecan monotherapy. She unfortunately complains of worsening abdominal pain and is confirmed now to have progressive disease. She inquires about immunotherapy for the treatment of ovarian cancer. Which of the following is true regarding immunotherapy in ovarian cancer? The correct answer here is B. Pembrolizumab is only appropriate if MSI high or dMMR when there's no satisfactory alternative. Now, immunotherapy is not very common in ovarian cancer until we get to a very heavily relapsed setting. But this is an important question because it comes up for numerous hematologic and solid tumor malignancies. A is incorrect because nivolumab is not FDA approved for microsatellite high tumors. It is approved for MSI high colorectal cancer specifically, but not MSI high solid tumors broadly. C is incorrect because pembrolizumab is not an appropriate option for maintenance therapy following any response in the primary or recurrent setting of ovarian cancer. Finally, D is incorrect because checkpoint blockade, including both nivolumab and pembrolizumab, should not be given in platinum-sensitive relapse. Rather, they should be reserved, pembrolizumab specifically should be reserved, when there's no satisfactory alternative. The very definition of platinum-sensitive relapse means that there are remaining options available. Switching gears to platinum-resistant recurrent ovarian cancer, now we're obviously not re-challenging with platinum-based combination therapies any longer. These patients have progressed either less than 6 months following completion of platinum-based therapy or during platinum-based therapy. So the decision here is going to be primarily based on prior therapies they've received, the comorbidities they have, their ability to tolerate therapy, and really their goals for therapy too. Are we looking more towards palliation? Are we trying to improve their quality of life while still prolonging progression-free survival as much as possible? And the agents we have are either single therapies or sometimes double therapies. So we have docetaxel, etoposide, gemcitabine. We have combinations with bevacizumab, which can include liposomal doxorubicin, oral cyclophosphamide, topotecan, or paclitaxel. And then we do still have the potential targeted agents as well. Our 3 PARP inhibitors can be utilized in this context if need be, or bevacizumab monotherapy. Lastly, in patients that we should have already done tumor molecular testing, this is where we're starting to think about different options. So patients that are MSI high tumors, you can actually consider pembrolizumab if there's no satisfactory alternative. And this is where this potentially really comes into play for ovarian cancer. Listed here, we just have some other potentially active agents in the context of heavily relapsed ovarian cancer. So again, we're looking primarily at monotherapies. We're trying to do something that can prolong progression-free survival as long as possible without causing too many untoward effects and too many toxicities. You'll see some additional agents such as aromatase inhibitors, anastrozole, letrozole, exemestane that can be used for some of our low-grade tumors. Targeted therapies, incorporation of entrectinib or larotrectinib for NTRK positive tumors. Trametinib can be used for low-grade serous tumors. But basically, at this point, we're looking at toxicity driving therapy. For our targeted therapies in the relapse setting, we know that we can use all 3 PARP inhibitors. So Olaparib is the first one that we could use. It was originally studied in Study 42 as treatment of relapse disease after at least 3 prior lines of therapy in patients that have a germline BRCA mutation. Again, this is going back to the prior capsule formulation, so it's 400 instead of 300 milligrams twice daily. But you can see the overall response rate, the objective response rate was 34%, including actually a response of 30% in patients that were deemed to be platinum resistant. Our next PARP inhibitor in the context of treatment of recurrent disease was studied in the ARIEL 2 study, looking specifically at platinum sensitive, but this is a study that helps to support its use also in the platinum resistant setting too. So this looked at patients with BRCA mutation as well as wild type and loss of heterozygosity, either loss of heterozygosity high or low. So it had a similar sort of tiered effect or efficacy. The median progression-free survival was significantly longer when you looked at BRCA mutated compared to loss of heterozygosity high and then loss of heterozygosity low, but all of them did show benefit. So it's definitely a tiered approach that we have more benefit with BRCA mutation as we might expect. Lastly, we have Niraparib, studied in the Quadra study. This was looking at recurrent disease. Patients received Niraparib at a standard dose. They had a median of 4 prior lines of therapy, and it included platinum-sensitive, resistant, and refractory disease. Again, we get the same sort of tiered responses that you're going to expect. Patients are going to respond the best with BRCA mutations, but there still is response with homologous recombination deficiency. Patients with platinum-sensitive disease are going to respond better than platinum-resistant, but platinum-resistant still did show response. So you see sort of a tiered response looking at this table here that we do have potential benefit even in patients with platinum-resistant disease and homologous recombination deficiency. The next couple of slides are more for your reference than anything. The PARP inhibitor landscape has really changed a lot, specifically in the last couple of years. But this lays out some of the different indications that are updated as of now anyway, and they're very likely to change in the future. But showing Olaparib and Niraparib in the frontline maintenance setting. Olaparib can actually be used in combination with bevacizumab if bevacizumab were part of the primary induction therapy. Clearly in the recurrent platinum-sensitive maintenance setting, we can use any of the 3 agents. And we can use any of the 3 agents in the setting of treatment of relapse disease too, but the indication is going to depend on the number of prior lines of therapy and their mutational status. This slide is also more for your reference. Here we have typical dosing of the 3 PARP inhibitors, as well as common class adverse effects, including myelosuppression, fatigue, and nausea. Notable adverse effects between different agents. For Olaparib and Rucaparib, you can actually see an elevation in serum creatinine, which is not indicative of renal dysfunction. However, it's more so related to inhibition of transporters that they can both cause. Olaparib can cause very rarely a pneumonitis. Rucaparib can have metabolic effects, including hypercholesterolemia and elevated AST and ALT. Niraparib more likely to have cardiovascular toxicities, including hypertension and palpitations. All 3 of them have a rare but severe potential adverse effect of causing MDS or AML. All of them are going to be reported anywhere between 0.5 and 2% recurrence. On the bottom, you can see some metabolic effects to keep in mind. To review the summary of recurrent ovarian cancer, we're looking primarily at platinum sensitivity. Again, 6 months is our cutoff for platinum sensitivity typically. So if we have a platinum-sensitive recurrence, we're going to be trying to maintain that platinum-based backbone. These are some of the platinum regimens that we have. Alternatively, on the targeted therapy side of things, we can use Niraparib and Bevacizumab for platinum-sensitive recurrence to try to spare chemotherapy for a patient if we need to do so. Platinum-resistant disease, we're looking more at single drugs, sometimes doublet drugs, including Bevacizumab. This is looking primarily at toxicity profiles, patient convenience, patients' goals to try to drive treatment decisions here. And then targeted therapies, we have our PARP inhibitors that can be used in the platinum-sensitive recurrent maintenance setting or as targeted therapy for recurrent disease treatment. In the context of heavily relapsed ovarian cancer, we need to keep in mind end-stage supportive care sequelae. This includes bowel obstruction, low-residue diets with frequent small meals, avoiding agents that may slow GI motility. Patients will often require paracentesis or thoracentesis for ascites that can accumulate recurrently and very quickly. Pain control, and it's very important to keep in mind the whole patient family. So the patient obviously is very important in priority number one, but it's important to keep in mind how we can best support the families as well. And now we'll transition to the management of hypersensitivity reactions. For our next audience response question, during SM's initial adjuvant chemotherapy following interval debulking surgery, she experienced a severe hypersensitivity reaction on cycle 6 of carboplatin. This was characterized by cough and shortness of breath. Which of the following is the proper sequence of managing a severe platinum hypersensitivity reaction? The correct answer is D. First, you want to stop the infusion. Stopping the offending agent in any hypersensitivity reaction is the first step. Then we need to look at pharmacologic intervention. In this case, we can give oxygen, but we should also be giving H1 and H2 antagonists and a corticosteroid. The H1 and H2 antagonists are more likely to help us with the acute hypersensitivity reaction, while the steroid can prevent delayed and rebound reaction. Option A is incorrect because here we're not giving any H1 and H2 antagonists, which would be necessary for the acute reaction. Now we're looking primarily at just preventing delayed and rebound reactions. Answer B is incorrect because there's no pharmacologic intervention for either acute or delayed reactions in this context. Similarly, option C is incorrect because it doesn't have pharmacologic management, but it also doesn't even have the very first step of management of a hypersensitivity reaction, which is to stop the offending agent. Thinking about hypersensitivity reactions to taxanes, these tend to be more mild. They generally resolve after stopping the infusion. They tend to consist of dermatologic manifestations such as flushing, pruritus, erythema. They may include cough or arthralgias and back pain. Generally with these, they occur in the first 1 to 2 exposures as opposed to platinum agents which occur later. Pre-medication schema is going to be very different between institutions, but just knowing that there is definitely a requirement for pre-medication to prevent hypersensitivity reactions. Hypersensitivity reactions to platinums, on the other hand, tend to occur later, so typically after 6 to 8 exposures. This is important to keep in mind for platinum-sensitive relapse, for instance, when we're re-challenging with platinum agents, or in oxaliplatin for gastrointestinal cancers. Patients have an oxaliplatin holiday. If we're re-challenging with platinum agents, they're still at markedly increased risk of hypersensitivity reactions. These tend to be more severe. They may require desensitization in the outpatient setting, and these occur more frequently as kind of classic allergic reactions. Looking at some of the signs and symptoms of hypersensitivity reactions. So first we have our mild hypersensitivity reactions. These are likely to be taxanes, liposomal doxorubicin. So we have more dermatologic manifestations, sometimes some discomfort, back pain, arthralgias. Getting closer to severe hypersensitivity reactions, you get some GI effects, nausea, vomiting. We can also have dyspnea, respiratory compromise, changes in blood pressure that may require intervention, and then life-threatening hypersensitivity reactions. We can have very severe hypotension. Clearly, you can have anaphylactoid type reactions, nausea, vomiting, and definitely respiratory distress. In the management of any hypersensitivity reaction, the first step is to stop the infusion. For mild reactions, we can administer an H1 antagonist. If there's any concern for delayed reaction, you can look at giving a corticosteroid. If it's resolving quickly, you can wait until symptoms resolve. And then if it's a taxane or liposomal doxorubicin, potentially even re-challenge on the same day at a lower rate. If it's not resolving quickly, depending on the symptomatology, if you think there's a risk of anaphylactoid reaction, then epinephrine could be appropriate. Severe reactions, we're doing everything we just did, but now we're looking at respiratory compromise, adding in those bronchodilators, administering oxygen, still giving H1 and H2 antagonists, as well as our corticosteroid. For life-threatening reactions, we're now adding recumbent position to maintain hemodynamic stability, oxygen, rapid boluses for hypotension, and following the ACLS guideline for possible cardiopulmonary arrest. That concludes this presentation. Thank you for participating.